Is ready for the poll whenever the poll appears on the screen. And if some of you have some question end of the session, please use the chat, or if you want to open up your line, please write down on the chat. We will open up your line for discussions. Thank you, Dr. Karthikeya. Over to you, please.
Thank you, Chandar, and welcome everyone. So today's topic is atrioventricular dissociation. I have actually purposefully kept this topic because there is a lot of confusion around the terminology that we use while discussing AV dissociation, and lot of confusion as well as in the diagnosis and where to use this term and what does that actually mean. So let's see. And today's talk will be mostly looking at the concepts, fundamental concepts related to AV dissociation, and will mostly cover many of the different ECGs rather than talk as such. So let's start with the cardiac conduction system. As for every talk, we know that the cardiac impulse arises in the SA node, which is the dominant pacemaker of the heart. And then the impulse goes to the right atrium, from where it goes to the left atrium through different interatrial tracts. And also from right atrium, it goes to the AV node and his bundle, which then divides into the right bundle branch and the left bundle branch. And then through a ramification of Purkinje fibers, the right and the left ventricles get activated simultaneously, resulting in a narrow QRS. So this is the normal cardiac conduction system. And you can notice here that there is only one pacemaker which controls the activation of both the upper atria as well as the ventricles. And this is the times when it is normally happening, and this we call it as AV association because there is only one pacemaker which is controlling both atria and the ventricles. Now, the same cardiac conduction system can actually travel in the reverse direction sometimes, which may be normal and may not be conducted, may not conduct retrogradely. That also is normal. So both ways it is possible. So again, now when we talk about the normal impulse from SA node or from atria to the ventricles, we use different terminology. One is called as antegrade, that is from atria to the ventricles. The others, because atria are higher and ventricles are lower, it is also known as the descending limb of conduction system. Similarly, when we talk about retrograde conduction, we may use the term retrograde in contrast to antegrade or anterograde, or the ascending limb of the circuit. So this is another way to call the direction of the cardiac conduction system. So as we understand that a single dominant pacemaker controls the atrial as well as the ventricular contractions. And but suppose this SA node does not fire or becomes very slow. Now we need ventricular impulse for ventricular contraction and formation of cardiac impulse for cardiac pulse. And so when the SA node does not fire, there will be subsidiary pacemakers in the form of AV node, his bundle, or fascicles, or sometimes even the ventricular myocardium, which will become the dominant pacemaker or as subsidiary pacemaker. But at any one point of time, whichever the pacemaker is uh, firing the fastest becomes the dominant pacemakers. All other pacemakers remain latent. And this is called as the concept of protection. And it is very important because uh, if all the pacemakers are firing at multiple rates, you can imagine what the chaos will be in the cardiac rhythm. So this is known as the concept of protection, so that the survival is maintained even if the dominant pacemaker fails to fire. And in abnormal conditions, these subsidiary pacemakers may have enhanced automaticity and may fire uh, whenever they are not needed also. And that is known as enhanced automaticity. And sometimes in abnormal conditions, the conduction from SA node, that is from the atria to the ventricles, may be uh, problematic. That is, there is a delay in conduction or block in conduction from atria to the ventricles, when we call this as atrioventricular block. So with this understanding, let's understand what is AV dissociation. Now, AV dissociation means that, as the name implies, the atria and ventricles are dissociated from each other. And so there is a dual rhythm. in which the atria and ventricles are activated independently. So as we understand, for normally, though we have one pacemaker, if there is an AV dissociation, there will be two pacemakers, one which will control the atria and the other which is controlling the ventricles. Now remember, a very important point in this talk is the purpose of this talk is that AV dissociation is never a primary or diagnosis, and it is always secondary to some other basic arrhythmia, some other rhythm disorders. And the common causes of AV dissociation are complete AV block during sinus rhythm, wherein the sinus node controls the atrial activation, whereas some other escape focus, depending on where the block is. Suppose the block is in the AV node, AV junction will control the ventricular rhythm, whereas if the block is in the infraesian in the bundle branches, then ventricular escape focus from the ventricular myocardium will control the ventricular rhythm. So this is one of common example of AV dissociation. The other common example is ventricular tachycardia. We all know that we consider AV dissociation as hallmark of ventricular tachycardia, but we'll see in further many examples what is the significance of AV dissociation in diagnosis of VT. So this is a very interesting or very important article by Alfred Pick, published way back in 1963. In fact, this AV dissociation is known to us for many, many decades, and there are many good articles by Alfred Pick. This is 1963 article. I will suggest whosoever is interested should read this article. The others are by Henry Marriott, whose ECG book we have been reading since our student days, and those articles are very important in understanding these concepts. Now he classified, because there is a lot of confusion regarding the terminology, he classified AV dissociation, and as you can see, AV dissociation is not the primary diagnosis. It is the effect of multiple causes, and the causes could be slowing of the primary pacemaker, as example the sinus node slowing, or acceleration of the subsidiary pacemaker, or block either from atria to the ventricle or from sinus node to the atria, or a combination of any of these three. So all these can cause AV dissociation. And let me just put on my pointer. So is my mouse visible now? And there are
Can
multiple,
follow.
is it visible?
Yeah, we can follow your mouse.
Okay. And there are multiple varieties of AV dissociation. Again, different terms have been used. So let's understand what these terms mean. And these varieties actually depend on the rate and regularity of the pacemakers. The pacemakers meaning one that is controlling the atria and the other that is controlling the ventricles. And the presence and degree of forward, that is antegrade, or the descending limb, and the retrograde block, the retrograde meaning the ascending limb of the cardiac conduction system. Now these varieties are complete. Now complete versus incomplete. Now one has to understand that the complete means that there is no capture beats. We'll see what capture beats are, whereas incomplete are associated with either atrial or ventricular captures. And the better terms which should be used rather than complete or incomplete are persistent or intermittent. Persistent means that the AV block is present throughout, whereas intermittent, it at times the AV dissociation is absent. So these are better term rather than using complete and incomplete. And in fact, the article by Pick also emphasizes that actually there is no significance of dividing AV dissociation into complete or incomplete, because presence or absence of captures does not increase the degree or uh, of the AV dissociation. In contrast to AV block, where the different degrees of AV block will depend on whether there is a delay in conduction, whether the block is incomplete, where some P waves can pass to the ventricles and others cannot, or complete, where no P waves can pass to the ventricles. Whereas complete versus incomplete AV dissociation just means, complete means that there are no capture beats, and incomplete means that there are atrial or ventricular captures. Now, so let's see what are the examples of AV dissociation, what is the different mechanisms. Now the Mechanisms could be either divided into disorders of impulse formation or disturbances of impulse conduction. Now, impulse conduction is simple. If you have AV block, the simplest example is that if you have no conduction from atria to the ventricle, so for survival, you have to have some other pacemaker which should control the ventricles, and the atria will usually be controlled by SA node, but there could be any other rhythm occurring in the atria, for example, atrial tachycardia, ectopic atrial tachycardia, atrial flutter, or whatsoever. But the ventricular rhythm will be maintained by some escape focus either in the ventricles or in the AV junction, which is beyond the site of AV block. Now, the more other common examples of AV dissociation or mechanisms could be disturbances of impulse formation. Now, whenever there is a late or delayed formation from the normal pacemaker, that is SA node, there will be sometimes what happens is that the subsidiary pacemaker will come in, and that rhythm, that beat will be called is late, and it is called as an escape beat. And if it continues for 3 or 4 more beats, then we call this as an escape rhythm. Now, the typical example is if you have sinus bradycardia, for example, in an athlete or during a vagal episode, you may have junctional escape rhythm, which may be occurring at the same rate or maybe a little faster than the sinus rhythm. So this is an example of AV dissociation due to late or delayed impulse formation. Another could be that the sinus node is acting normally and firing at it is normal rate, but the subsidiary pacemaker has enhanced automaticity and it is firing a little faster than the sinus node. And the typical example that all of us have seen while treating myocardial infarction when we give thrombolytic agent, there is an arrhythmia which is known as accelerated idioventricular rhythm, wherein the ventricular rate is faster than the sinus rate, and sometimes the atrial and the ventricular rates compete with each other. And this is what we call it as isorhythmic AV dissociation because the atrial and ventricular rates are nearly similar. The third example could be that there is enhanced abnormal impulse formation with retrograde block. Now, during AIVR, the subsidiary pacemakers were firing faster, slightly faster than the SA node, but these were the normal subsidiary pacemakers. But there could be the other areas which do not have pacemaking ability. For example, ventricular myocardium, which may beat very fast and with and this may not conduct back to the atria through the ascending limb or in the retrograde direction because of AV nodal refractoriness, and then this will result in AV dissociation because the ventricular rhythm is then maintained by the ventricular tachycardia focus, whereas the atrial rhythm will be maintained by the sinus node. So these are the different mechanisms of AV dissociation uh, and with these examples. So let's see what are the signs of AV dissociation. Now, the signs of AV dissociation, the clinical signs, it is important for medical students because that may be asked in the exams. And the typical signs are intermittent Canon A waves in the JVP. Because of the AV dissociation, the atria may contract when the tricuspid or the AV valves are closed, and that may result in intermittent Canon A waves. The other findings are variable intensity of the first heart sound, and if you have a blood pressure tracing, you may have beat to beat variation in the blood pressure. On the ECG, the typical signs of AV dissociations are that the P waves are independent of the QRS complexes. There are capture beats and there are fusion beats. We'll see what these signs are. Now let's understand a few terms that we often use and they are a cause of a lot of confusion. Now, escape beat. As I said, if the primary pacemaker or the dominant pacemaker does not fire, something will take over, that is from the subsidiary pacemaker, but that will come late, and so that is known as an escape beat. And if it continues for 3 or more beats, we call this as an escape rhythm. So this is an escape beat, and it is from an ectopic focus, not from the sinus node. The other term that we often use is premature beat. We know ventricular premature beat, atrial premature beat. Now, as the name suggests, the premature beat occurs prematurely or early. As we see in this example of this tracing ECG, you see that the sinus rhythm is going on, but this premature beat from the atria, this is an atrial premature beat. and then it also conducts to the ventricles antegradely. And so this premature beat here has one-to-one AV association, and so there is no AV dissociation here. However, in the other example, other tracing, you see that the sinus rhythm is going on, but then there is a wide QRS beat comes a little early, and this is a ventricular premature beat, comes just after the P wave. But you can understand that this PR is very short, and so this is not possible that this P wave conducted to result in this QRS. And so here in this single beat only, you see that the P wave and the QRS complexes are dissociated from each other. So this is a premature ventricular premature beat wherein you have AV dissociation only for this single beat. Otherwise, the sinus rhythm is continuing regularly as uh, seen in the ECG rhythm strip. Now other beats is capture beat. Now what do you mean by capture? Now capture could be either ventricular capture or atrial capture. Now capture means if you have a rhythm, we'll see in examples when we have uh, uh, AV dissociation going on, the sinus beat, some of the sinus beats may find the AV node non-refractory and conduct to the atria. So during a period of AV dissociation, you find that one of the beat in the atrium conducts to the ventricles and depolarizes the ventricular totally, and total ventricular activation is as a result of conduction from the AV node His-Purkinje system, and this is known as total capture beat, where the QRS morphology will resemble that of a normal QRS. Whereas the other term that we often use is partial capture beat, and more commonly it is known as a fusion beat, where the same premature beat, the atrial beat will conduct back to the ventricles, but at the same time the ventricular activation is also occurring through the other focus, other pacemaker which was acting in the ventricles. So the ventricular activation occurs as a result of fusion of activation from the atrial beat which conducts from the normal AV node His-Purkinje system, as well as from the ventricular tachycardia or whatever the ventricular pacemaker was. And so this is known as a fusion beat. We'll see examples. Complete or incomplete AV dissociation, I've already told, whenever there is absence of capture beats or presence of capture beats, we call this as complete or incomplete AV dissociation. Apart from making your diagnosis of AV dissociation or the underlying disorder more apparent, there is not much significance of complete or incomplete AV dissociation. The better terms to use are persistence or continuous and or discontinuous AV dissociation. Another term which is often not understood because there's a lot of confusion in its terminology is interference dissociation. And since there is a lot of confusion, most of the authors, including Marriott, have suggested that we should abandon this term and not use this term altogether. Now let's understand the fusion beats in more detail. Now, when we have the uh, as I said, during an AV dissociation, for example, in this example, you find that this is the atrial activation is through the sinus node, whereas the junctional rhythm is controlling the ventricles. Now, this junctional rhythm can also retrogradely go back to the atria, and if the timing of the junctional beat is such that the retrograde activation of the atria also collides with the atrial activation occurring from the atrial pacemaker, that is the SA node, then the atrial activation is occurring as a result of fusion. And so this is atrial fusion and due to retrograde activation. On the other hand, if there is a ventricular tachycardia going on and you find that one of the atrial beats finds the AV node non-refractory and conducts through the AV node His-Purkinje system, and so the ventricular activation occurs as a result of fusion of activation from AV node His-Purkinje system as well as from the ventricular tachycardia focus, and this is known as ventricular fusion. So the dissociated impulses meet in atria in AV junction or the ventricles will depend on the relative times of discharge of the two pacemakers the other in the ventricles and the rate of antegrade and retrograde conduction. If the collision or the of the atrial and ventricular impulses, that is the dissociated impulses, occurs in the AV node, then this will not be apparent on the ECG, and so you will not find any fusion beat on the ECG. Whereas if you find this occurs in the atria, you will find atrial fusion beats, or if it occurs in the ventricles, you will find the ventricular fusion beats. So let's come to the examples. So this is the first ECG, and so there are two questions associated with ECG. The first is a simple question: is AV dissociation present? And the choices are A yes and B no. So let's put the polling question here. So for these simple questions, I think we can look at the answers quickly. And so everybody agrees that there is AV dissociation present. So before discussing, let's get the other question. So the ECG shows, and the choices are A, third degree AV block, B, junctional escape rhythm, C, site of block can be AV node, and D, all of the above. Chandra, can you put up the poll question? So let's see the answers. So majority of you are right. So this is the answers are all of the above. And so the ECG, let's go through this ECG. Now you see, let's look at the P wave. So you have the first P wave here. I believe my pointer is or mouse is visible. So the first P wave is here. The second P wave is on the T wave of the next QRS. And the third P wave is here. Fourth is again here. Fifth is here, somewhere here. And sixth is here. So you see there are more P waves than QRS complexes. And the PP intervals look grossly normal. The P waves are upright in leads 2, 3 and AVF, inverted in lead AVR, and they are biphasic in lead V1. So there is sinus rhythm. The atrial rate is around how much? Around 70 beats per minute, 60 to 70 beats per minute. And the number of QRS complexes are much less than the number of P waves. So if you look at the the RR intervals are also regular. The QRS complexes are narrow and they are normal looking. So the PP intervals are regular, RR are regular, no apparent PR interval is constant. So this is third degree AV block. So atrial contraction is taken by the pacemaker of the atria is the SA node, whereas the pacemaker of the ventricles is the AV junction. Because the QRS is normal and narrow, the ventricular pacemaker is through the AV junction. And there is no conduction from the atria to the ventricles, and atrial activity is independent of the ventricular activity. So this is third degree AV block with sinus rhythm, with third degree AV block, with junctional escape rhythm. And since the QRS is narrow, the block cannot be infrahisian. It has to be either AV nodal or intrahisian. So the correct answer is all of the above. There is another very interesting observation, if somebody might have noticed, that if you look at the PP intervals, though they are grossly normal, there is some irregularity. If you measure the PP interval which has a QRS in between, that PP interval is shorter compared to the PP interval which does not have a QRS. This one is longer, this is also longer, but this one which is encompassing a QRS is shorter. Now, this irregularity in PP intervals is not dependent on the phase of the respiration, and it is dependent on the presence or absence of QRS complex. And this is known as ventriculophasic sinus arrhythmia, wherein the ventricular complex, that is ventricular contraction, results in autonomic influence through the sympathetic and parasympathetic nervous system, which makes if there is a ventricular contraction, this makes the atria to beat a little faster based on the increase in the sympathetic nervous system activity. So this is known as ventriculophasic sinus arrhythmia. So the correct answer is sinus rhythm with complete AV block and junctional escape rhythm. So this is a type of AV dissociation due to conduction disturbance. And remember that all complete heart blocks have AV dissociation. So complete heart block here, the atrial rhythm could be either sinus or ectopic atrial rhythm or ectopic atrial tachycardia, flutter or fibrillation, but there is no AV relationship, and the ventricular rhythm is through an escape focus that can arise distal to the site of AV block, either in the AV junction, fascicular or ventricular, and typically the atrial rate is more than the ventricular rate. Now remember that every complete heart block has to have AV dissociation. Now let's look at another example. This is an ECG in a young male with normal, structurally normal heart, and it shows we can have the choices here. The choices are ventricular tachycardia with VA dissociation, ventricular tachycardia with VA association, C SVT with left bundle branch aberrancy, and D AF with ventricular pre-excitation. Remember, this talk is on AV dissociation. That doesn't mean that every ECG that I show will have AV dissociation. So take your time, look at the ECG and look at the choices and then answer your question. So can we have the answers now, please? Correct. So most of you, majority of you said ventricular tachycardia with VA dissociation, and that is the correct answer. So let's look at this ECG in detail. So you have a wide QRS tachycardia. The rate is not very fast. Rate is around just more than 100, around 115 or 116 beats per minute. And the QRS is wide, and it is predominantly negative in lead V1. So we will say to be left bundle branch block type morphology. And if you look at the features, you find that the V1 LBBB type morphology, you have inferior axis and you have QS complexes in lead AVR and AVL. Now LBBB with right axis makes it more suggestive of VT. And if you look at the intrinsic coil deflection from the onset of Q wave to the peak of the R wave is quite long compared to the terminal part. So that suggests that the initial activation is not mediated through the His-Purkinje system and is likely myocardial, again suggesting VT. Now, the other thing which suggests VT is that the QRS morphology does not resemble the typical left bundle branch block pattern, and so this is unlikely to be SVT with aberrancy. Similarly, it does not fit into any pre-excitation pattern also, plus the RR intervals are not, they are predominantly regular, they are not markedly irregular, and so this is not atrial fibrillation as well. So the choices C and D are ruled out. Now let's see, it is most likely ventricular tachycardia, but whether do we have VA dissociation or VA association? Now let's look at the rhythm strip. You find that there are wide QRS complexes, but you see that this QRS complex is a little narrow. And if you go further, you find another QRS complexes which is narrow, and another one which is even narrower and probably normal looking. And then you have another QRS which is also narrow. So in between the wider QRS complexes rhythm, you find there are multiple types of other QRS complexes which look like a normal QRS, and this is probably what we call it as a capture beat, because a P wave which comes at a time where the AV node is non-refractory conducts to the AV node His-Purkinje system and activates the ventricles, resulting in this ventricular activation occurring through the normal AV node His-Purkinje system, resulting in a narrow QRS. Whereas the other times where the QRS morphology is in between that of a VT QRS and, the normal QRS, this is occurring as a fusion activation, where the ventricular activation is occurring as a fusion between the ventricular tachycardia focus as well as the normal ventricular activation through His-Purkinje system. So these presence of fusion beats and capture beats, if we measure these RR intervals precisely using calipers, you will find that these fusion beats as well as the capture beats are a little earlier than the RR intervals during the wide QRS beats. So these fusion and capture beats indicate that there is AV dissociation present. And if you look at carefully, you find that the P waves, you can mark out where the P waves are. So this is a P wave which is positive in lead 2. Another P wave is this. Next one is this, which results in a fusion beat. Next one is again this and this. So you find that the PP interval is also regular and the PP number of PP intervals, P waves is much lesser than the number of QRS complexes, and the P waves are upright in leads 2, 3 and AVF, indicating that the atrial activation is occurring with the sinus node, the ventricular activation is occurring with the during with you from the VT focus, and at times the atrial activation is able to capture the ventricular activation either completely resulting in a narrow QRS or incompletely, which results in a fusion beats like these beats which are in between morphology between the wide QRS VT beats and the normal QRS narrow beats. And the morphology of this QRS actually tells you that this is arising from the outflow tract. And so this is ECG of a patient with idiopathic VT arising from septal side of RVOT with AV dissociation and capture and fusion beats. Now remember, when we have AV dissociation in the form of capture and fusion beats or less number of P waves than QRS complexes, this is a hallmark of AV dissociation and tells you that you are dealing with ventricular tachycardia. But absence of AV dissociation does not mean that it cannot be a VT. So that's another important point that one should take in home, that absence of AV dissociation does not rule out VT. And in fact, 40% of ventricular tachycardias either have some kind of VA association or VA dissociation is not visible on the ECG. So ventricular tachycardia with AV dissociation ventricular reentrant circuit. The atrial rhythm is usually sinus, but remember, can be AF, flutter, or could be unrecognizable as such. The retrograde atrial activation, if it is present, that is the VT focus conducts back to the atria regularly in whatever fashion, 1-1, 2-1, 3-1, or 4-1, then it is not AV dissociation. Then it is a VA association with the whatever the degree of conduction from ventricular to atria is. So AV relationship during AV dissociation will be none unless VA conduction is present, and typically the ventricular rate is more than the atrial rate, but sometimes you may have dual tachycardia. For example, you may have atrial flutter or atrial fibrillation with ventricular tachycardia going on simultaneously, where the number of atrial complexes may be more than number of ventricular complexes, but the regularity of the ventricular beats and the QRS morphology will tell you that it's a dual tachycardia with AF and VT going on simultaneously. Now let's look at another example, and we have the polling question also here. The following ECG shows the choices are A, sinus rhythm, B, AV dissociation, C, junctional rhythm, and D, all of the above. I think, sorry for the mistype, this is A, sinus rhythm, B, junctional rhythm, C, AV dissociation, and D, all of the above. So let's have the answer now. So again, it's a mixed choice, but the correct answer is all of the above. Uh, all of you actually had, I think it's a quite an even split, but the correct answer is all of the above. Let's see why. Now let's look at the rhythm strip. The QRS complexes look normal. Let's look the rhythm strip, which is the most important in this ECG. If you look at the first uh, 5 QRS complexes, this is a normal sinus rhythm with normal antegrade conduction through the AV node His-Purkinje system and a normal QRS. Now the sixth QRS, and from then on you find that the QRS complexes look same, but the PR interval is shortening, and then you find that the P wave get actually lost in the QRS. And for the last two QRS, you have the sinus rhythm again with normal QRS looking with the normal PR interval. But for the in between six QRS complexes, you find that the P waves and QRS complexes are actually occurring at nearly the same time, and the PR interval is physiologically not possible. Whatever the PR, apparent PR is physiologically not possible. So this P wave here is dissociated from this QRS complexes. And since the QRS complex morphology is the same, so this is an junctional rhythm, but it is a little faster than usual junctional rhythms should be. So this we call it as accelerated junctional rhythm, occurring at a rate of say 75 beats per minute, and the sinus rate is also nearly the same 75 beats per minute, and you find that the 6 beat in between are having AV dissociation. These P waves are not this in during these 6 beats. The atrial activation is controlled by the sinus rhythm, whereas the ventricular activation is controlled by the junctional accelerated junctional rhythm. And so there is a dual rhythm, and there is no the atria and the ventricles are beating independently of each other. So this is an example, as I said, of the third type, where you have enhanced automaticity from a subsidiary pacemaker, whereas the normal pacemaker is firing normally. So this is an example of AV dissociation due to enhanced automaticity of the subsidiary pacemaker. And since the atrial and the ventricular rates are nearly the same, we call this as isorhythmic AV dissociation. So this is another type of AV dissociation, and the correct answer is, if you look at this red bar, it is the time when the P waves and QRS complexes are dissociated from each other. So this is intermittent accelerated junctional rhythm with isorhythmic AV dissociation. So this is a type of AV dissociation due to interference. The interference is occurring in the AV node, that is the sinus rhythm, it's getting collided with the junctional rhythm retrogradely conducting to the AV node. And so the atria and ventricles are dissociated, with atrial activation occurring through the sinus node and ventricular activation occurring through the ventricular node. So this gives you one more example wherein it proves that all AV dissociations are not complete heart blocks. We just saw an example of complete heart block with AV dissociation. We saw an example of ventricular tachycardia with AV dissociation. This is another example where there is neither complete AV block nor ventricular tachycardia, is some accelerated junctional rhythm. And so AV dissociation is not synonymous with complete AV block. I have heard many of the times, especially cardiac surgeons saying this patient is having AV dissociation, see whether this patient needs a pacemaker or not. Now this is an inappropriate term to use, because we just said, though we understand what the surgeon is likely to be saying, but it is not a correct term to use, because AV dissociation can occur in VT as well as in this scenario like an accelerated junctional rhythm. Now let's look at another ECG. Now this is an ECG of an asymptomatic athlete and shows the choices are junctional escape rhythm with AV dissociation, B sinus rhythm with marked first degree AV block, C AV dissociation, and D none of the other above. So most of you have said junctional escape rhythm with AV dissociation. So that's not the correct answer. Let's look at what's happening here. Now you find that this is a QRS which is narrow and normal looking narrow QRS. So the ventricular activation, and it is not preceded by any P waves. So this is arising in the AV junction. There is no doubt. I think most of you agreed that. So this is junctional rhythm. And since there is no preceding P waves and the rate is slow, that means if at all there is a sinus node firing, it is occurring even at a much slower rate. And that's why the junctional rhythm has taken over as the normal pacemaker of the ventricles. And since it is coming late, we will call this as junctional escape rhythm. Now let's see, ventricular rhythm is controlled by the junctional escape rhythm, but what is controlling the atria? Now let's look if you can make out where the P waves are. So there is no P wave preceding the QRS complexes, but what's happening after the QRS complex? You see a inverted kind of a deflection after the QRS complex in lead 2 as well as in lead 3 and in lead AVF. And this is corresponding to this is an upright deflection in lead AVR and AVL and a positive deflection in lead V1. So this activation, and it is a narrow deflection, this is a P wave, and the atrial activation, the morphology of the P wave suggests that it is not sinus because it is inverted in lead 2, 3 and AVF, upright in AVR and AVL. It is telling you that it is occurring from below upwards. So either it could be an atrial activation occurring from the low interatrial septum, or it could be retrograde conduction from the junctional focus. Now, if it is an atrial activation from this interatrial septum, why it should come just after the QRS all the time? It is very rarely possible that this ectopic atrial rhythm may conduct with a very long PR to form this QRS complex, but that would be very, very highly unlikely. Which is more likely is that this AV junctional focus conducts retrogradely and activates the atria and results in this P wave morphology, which suggests retrograde atrial activation. So here the ventricular rhythm is controlled by the junctional focus that everybody understands, but the atrial activation is also controlled by the junctional focus through retrograde atrial activation. And so if you look the heart in totality, there is only one pacemaker, that is the AV junction. So there is no AV dissociation here. Both the atria as well as the ventricles are controlled by the junctional focus, and so the correct answer is none of the above, since it is not, it is a junctional escape rhythm, but there is no AV dissociation here. And since the P wave morphology is not that of sinus beat, it is not sinus rhythm. And as I explained, there is no AV dissociation. The correct answer is D, none of the above. This is junctional rhythms with retrograde 1-to-1 VA conduction. So the correct answer will be junction rhythm with retrograde atrial activation and 1-to-1 VA association. So we just saw an example of a junctional rhythm which had accelerated junctional rhythm which had AV dissociation, but here you have junctional rhythm but 1-to-1 VA association. So all junction rhythms do not necessarily have AV dissociation. Now let's look at another example. The ECG shows atrial fibrillation with complete AV block, sinus bradycardia with first degree AV block and right bundle branch block, sinus tachycardia with third degree AV block and wide QRS escape rhythm, and D, sinus tachycardia with 2-to-1 AV block and right bundle branch block. Let's have the polling question. So the polling question shows a little different order, but we will go by what the polling question says. So let's have the answers. So there is a tie between sinus tachycardia with 2-to-1 AV block and sinus tachycardia with third degree AV block. So let's look at the ECG. The correct answer is sinus tachycardia with third degree AV block and wide QRS escape rhythm. So let's look at the rhythm strip. Now you see that you have P waves which are upright. This is rhythm strip lead 2 and lead 1 in fact. And if you find that the P waves are positive in lead 2, 3 and AVF, the atrial rate, if you look at the atrial rate, it is just above 100. So this is sinus tachycardia, can't be sinus bradycardia. And if you follow the P waves, you find that the number of P waves is much more than the number of QRS complexes. And so there is some degree of AV block, either second or third degree, because in first degree AV block, the PR interval is long, but each P wave conducts to the ventricles. So let's look whether it is second degree or third degree AV block. Now, if you look at the apparent PR intervals, they are constant. They are not constant. They are changing it from beat to beat. So this cannot be second degree type 2 or 2 to 1 block. It could either be Venki back or it could be third degree AV block. Now, if you look at, if it were to be Venki back block, the PR interval should gradually increase and the RR interval should be irregular. But here we find that the PP intervals are constant, the RR intervals are also constant, and the apparent PR intervals are varying. So this is diagnostic of complete or third degree AV block. And so this is an example of sinus tachycardia with third degree AV block or complete AV block with a wide QRS escape rhythm with right bundle branch block type pattern, and which is a common type of AV dissociation. This is a very common ECG that we typically see in old patients who present to you with recurrent syncope and at times may be asymptomatic also. So this is a simple complete sinus tachycardia with complete AV block and a very common type of AV dissociation. Let's look at another example. This ECG in a patient with repaired tetralogy of Fallot shows choices are, can we have the choices? Atrial fibrillation with right bundle branch block, atrial flutter with complete AV block and wide QRS escape rhythm, atrial flutter with 4 to 1 AV conduction and RBBB, or D, none of the above. So let's have the answers. So I'm glad most of you are accurate. So this is atrial flutter with 421 AV conduction with RBBP. So let's look at this ECG. Now you have, if you look at leads 2, 3 and AVF, you have inverted P waves, which are well-formed P waves and are regular with an atrial rate of say about 6 or around 250 beats per minute. And you have QRS complexes which are wide QRS and is showing right bundle branch block type morphology and left axis in the frontal plane. We do not have any rhythm strip here, but if you look at the PR interval of apparent PR interval of any beat, the PR interval looks same in all the beats. So that means that there is AV association. And if you look at the number of P waves preceding each QRS, so you have 1, 2, 3 and 4 P waves for one QRS complex. So this is atrial flutter with 4 to 1 AV conduction and right bundle branch block. Now the typical morphology of the typical counterclockwise atrial flutter is P waves which are negative in lead 2, 3 and AVF and positive in lead V1, which we see here. So this is an example of a typical cavo tricuspid isthmus dependent right atrial flutter occurring in counterclockwise fashion and conducting in 4 to 1 uh, 4 to 1 AV ratio and right bundle branch block. Right bundle branch block is in fact very common in patients where with repaired congenital heart disease, whenever you do a ventriculotomy, you will see right bundle branch block, and it is usually a distal type of right bundle branch block. Let's see another example. What do you see here? So I have not put polling questions here, but what you see here is the in lead V1 you find that there are P waves which look well formed, but if you look at other leads, the P waves are not very well formed and they are not of the same morphology. And the atrial rate is also varying. So this is what we call it as coarse atrial fibrillation and with irregular PP intervals. And but if you look at the RR intervals, the ventricular rate is slow and the RR intervals are regular, which we do not expect in atrial fibrillation. So this means that this patient has complete AV block and the ventricular rhythm is being maintained by the QRS complexes generated from the AV junction. So this is junctional escape rhythm and atrial fibrillation. So this is again a dual rhythm. The atria is fibrillating, whereas there is complete AV block and the ventricular rhythm is controlled by the ventricular focus. Now you see some T inversion lead V3, V4 and V6, and this is likely because patient was on digoxin, and this AV block was actually therapeutically done because this patient's ventricular rate could not be controlled, and so the AV node was ablated so that the good rate control can be achieved, and then a permanent pacemaker was implanted in the ventricle. So this is again an example of AV dissociation where the atrial rhythm is atrial fibrillation, there is complete AV block and a junctional escape rhythm controlling the ventricles. So the take home from this ECG is that if you have a slow regular ventricular rhythm during atrial fibrillation, it suggests complete AV block, and it is sometimes seen in patients with digoxin toxicity or can occur in patients who undergo valve surgery due to post-operative trauma, or it could have been therapeutically done as a means of rate control strategy by doing radiofrequency ablation. Now let's look at another example of an ECG. ECG of a patient with palpitation shows the choices are A, atrioventricular reentrant tachycardia, B, junctional ectopic tachycardia, C, atrial fibrillation, and D, ventricular tachycardia. This is a little difficult ECG to understand. So can we have the polling questions, please? I put this ECG, this is a rare ECG, and a little difficult, but this should make your concepts about AV dissociation more clear. So can we have the answers, please, now? Oh, that's surprising that most of you actually got it correct. So this is junctional ectopic tachycardia. So I think you are getting the concept of AV dissociation. So let's go to this ECG. First of all, if you look at the RR intervals, they look slightly irregular. But remember that whenever you have presence of capture beats or fusion beats or some change in QRS morphology, they may give you a appearance that the rhythm is irregular, and then you have to measure it precisely using calipers. And I will tell you that these RR intervals are totally regular. So what you are dealing with is a narrow QRS tachycardia, narrow QRS regular tachycardia. QRS complexes look normal. But what about the atrial activation? Now, if you have to look at the P waves, look at lead 2 in the rhythm strip. So you have one P wave here, another one here, next one likely buried in this QRS, distorting the QRS morphology. Next one again here. We just need to mark out the P waves and then you can follow them at their expected time. So you see that the P waves are occurring at their expected times, and at times they are distorting the QRS complex, and at times they are occurring after the QRS, and sometimes they are occurring before the QRS, causing a capture beat. That is, the next R wave or QRS complex comes a little earlier. So, and the number of P waves is much less than the QRS complexes. So you have a narrow QRS tachycardia where the P waves are less than the QRS complexes, and the atrial activation is looks like it is maintained by P waves which are positive in 2,3 AVF, meaning that they are from the sinus rhythm. So atrial activation is from the sinus rhythm, and where is the ventricular activation coming from? Since the sinus rate is slower, it cannot go to the ventricles in a faster rate. And since the QRS morphology is normal, it is coming from the AV junction, and so we call this as junctional ectopic tachycardia. Now from the junction, there is retrograde block. It is not going to the atria, but coming to the ventricle. So ventricular rhythm is through the junctional ectopic focus, but the atrial rhythm is through the sinus rhythm, sinus node, and there is no link or association between the atrial activity and the ventricular activity. And so this is an example of junctional ectopic tachycardia with AV dissociation. This is a rare tachycardia in adults, but it is frequently seen in children, especially with after surgery for congenital heart disease. And we see this very commonly. Now this explains to you that all uh, 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 tachycardias with AV dissociation are not necessarily ventricular tachycardias. Now suppose this patient with the junctional rhythm had an aberrancy in the right bundle or right bundle branch block. Same tachycardia, same focus, but also has right bundle branch block in addition, then it would have presented as a wide QRS tachycardia. So this wide QRS tachycardia with AV dissociation is not a ventricular tachycardia. So remember, though we say that AV dissociation is an hallmark of ventricular tachycardia, presence of AV dissociation only tells us that atria and ventricles are activating independently of each other. And since statistically VT is much more common than junctional tachycardia, we can say that practically all wide QRS tachycardias are likely to be with AV dissociation are likely to be VT. But remember that one of the possible rare differential diagnosis could be junctional tachycardia with aberrant intraventricular conduction and retrograde block that can result in a wide QRS tachycardia with AV dissociation. So this is sinus rhythm with junctional ectopic tachycardia with AV dissociation. So JET is an example of narrow QRS tachycardia with AV dissociation. There are few other rare examples which can cause narrow QRS tachycardia with AV dissociation that I'll not be covering in this talk. Let's see a couple of more ECGs and then we'll close. So this is a wide QRS tachycardia in a patient with old inferior wall MI and LV dysfunction, and it shows the choices are A, sinus rhythm with VT and AV dissociation, VT with AV association and retrograde 1-to-1 conduction, C, SVT with RBB aberrancy, and D, atrial flutter with 2-to-1 conduction and right bundle branch block. Can we have the poll questions again, please? Chandar, can we put the polling questions, please? Yeah, thank you. Let's have the answers. So we have a mix of answers. So let's look at this. Now suppose I don't have not given you this ECG. If I say that it is a wide QRS tachycardia in a patient with old inferior wall MI and LV dysfunction, what should be your answer? Even without looking at the ECG. If you say ventricular tachycardia, you will be right 98% of the times. So always look into the clinical history of the patient before coming to your conclusion. And if we let's look at the QRS complexes or the ECG now, you see that it's a wide QRS tachycardia with positive complexes in lead V1 with R more than R dash, which is suggestive of right bundle branch block type pattern. And what you have is a northwest axis. So northwest axis, that is lead 1 showing negative QRS, lead AVF also showing negative QRS. Northwest axis during a wide QRS tachycardia goes in favor of ventricular tachycardia. Another pointer is that if you look at the QRS in lead V6, the S wave is larger than the R wave. That also suggests that it is ventricular tachycardia. Now remember the ventricular tachycardia will also tell you, the ECG during VT will also tell you what is the underlying substrate. So you find that there are large Q waves in lead 2, 3 and AVF and some ST elevation in lead 2, 3 and AVF, indicating to you that there is possibly old inferior wall MI and possibly a scar in the inferior wall of the left ventricle. And the the title of the topic of the today, if you look at the rhythm strip, you find that in between these white QRS beats, you find there are certain deflections which are occurring at an independent rates which are positive. So these are positive P waves occurring at a much slower rate, indicating a AV dissociation. So number of P waves is less than QRS complexes. There is only one deflection which suggests that possibly this may be a fusion beat. Otherwise, there is no capture of fusion beat except possibly this last but third QRS complex. So this is a wide QRS tachycardia due to ventricular tachycardia in a patient with the old inferior wall MI with AV dissociation. The atrial activation is through the sinus rhythm, and ventricular activation is through the ventricular tachycardia focus. Now let's look at another example quickly. A 37-year-old lady underwent mitral and tricuspid valve replacement surgery, and the ECG on the third post-operative day shows. Chandra, can you put on the questions, please? A, atrial flutter with complete AV block. B, atrial flutter with 4 to 1 AV conduction. C, sinus rhythm with artifacts. And D, atrial flutter fibrillation with digitalis toxicity. So let's look at the answers. So most of you said that it is atrial flutter with 4 to 1 conduction. So, and that's not the correct answer. Now remember, whenever you're talking about atrial flutter, your diagnosis is correct. You see inverted P waves in loop 2, 3 and AVF and upright P waves in lead V1, indicating typical right counterclockwise atrial flutter. But do not assume that this patient has antegrade AV conduction, intact AV conduction. So for that, you have to look at the QRS complexes and the QRS, the RR regularity or irregularity, and the PR intervals, apparent PR intervals. So you find that the QRS complexes are a little wide of the left bundle branch block type pattern, and the RR intervals are quite regular. And if there were to be AV conduction, intact AV conduction with regular RR intervals during atrial flutter, one should have PR interval which are constant in all the QRS complexes. Now let's look at the PR interval in the first beat here. You find that the PR is quite long, and let's look at the PR interval in the last beat in the rhythm strip. The PR is quite short. So if it were to be atrial flutter with 4 to 1 AV conduction, then the PR interval in each of the QRS complexes should have been identical, and the RR should have been regular. RR is regular, but the PR intervals are not constant. So it suggests that this is complete AV block. And as many of you answered 4:AV conduction, our surgeon also did not believe this. And so what we did was we cardioverted this patient. And what did cardioversion do? Now the answer becomes very clear. The after cardioversion, the atrial flutter terminated, but there was no AV conduction, and the ventricular rate did not budge. It remained the same with the same QRS morphology, except for this one ectopic beat. The QRS morphology remains the same, and you see that the atrial rate is now sinus around 100 beats per minute, and there is no association between the P waves and the QRS complexes. So this is sinus rhythm with complete AV block with wide QRS escape rhythm. So this previous ECG was atrial flutter with post-operative complete AV block and wide QRS escape rhythm, and AV dissociation wherein the atrial activation is by the atrial flutter and ventricular activation was by the ventricular escape rhythm. So I'll come with so just saying that complete AV block is not enough. One have to specify the atrial rhythm. So these are two messages from this ECG. Just saying complete AV block is not enough. You have to see what is the atrial rhythm. So the answer should have been sinus rhythm with complete AV block with ventricular escape rhythm, or in this ECG, atrial flutter with complete AV block with ventricular escape rhythm. Secondly, whenever you have atrial flutter, please remember to look at the AV conduction ratios, whether you have intact AV conduction. If yes, what is the AV conduction ratio, whether it is 2 to 1, whether it is 4 to 1. Especially if the rate is slow, always suspect complete AV block, and that you can look at looking at the PR intervals of the during the rhythm strip. If the RR intervals are constant, the PR interval should also be constant if there is intact AV conduction. Now I'll end with this last ECG and then conclusion. So this is an ECG of a patient with old MI and palpitation, and it reveals, Chandra, please put on the polling questions. A, sinus rhythm with VT and AV dissociation. B, VT with AV association and retrograde 2 to 1 conduction. SVT with aberrant conduction, and D, atrial fibrillation. Very good. So your most of you answered it correctly. It is VT with AV association and retrograde 2 to 1 conduction. So let's look at this ECG. First of all, this ECG is actually a very good teaching ECG with very good teaching points. So let's look at the ECG in detail. Now let's look at rhythm 2, the rhythm strip. So if you look at the rhythm strip, now lead 2 is often used as a rhythm strip in ECG monitors. If you just look at lead 2 and don't see the other leads of the 12 lead ECG, it may look like a narrow QRS tachycardia. Now remember that you cannot make a diagnosis of narrow or wide QRS just based on one ECG, because as I said during my earlier sessions, the first part of the QRS or the last part of the QRS may be isoelectric and may fool you in believing that this is a narrow QRS tachycardia. If I were to ask you what is the QRS duration in lead V4 or V5, nobody will have doubt that it is a wide QRS tachycardia. But looking at lead 2, I think most of you will say that this is a narrow QRS tachycardia. So this is a wide QRS tachycardia with small signals in lead V1, which is not very clear whether it is negative or positive. But let's believe that this is negative. So you have negative QRS complexes from V1 to V6, which is negative concordance, which we call it as negative concordance, suggesting ventricular tachycardia as a diagnosis. The lead 1 is showing negative complexes, AVF is positive, so this is right axis deviation, and with left bundle branch block, so this is left bundle or bundle branch block QRS axis discordant pattern, again suggestive of ventricular tachycardia. Now, so the RR intervals are quite regular. So atrial fibrillation is ruled out. The QRS morphology does not look like typical left bundle branch morphology. So SVT with aberrant conduction is ruled out. Now, whether it is sinus rhythm with VT and AV dissociation or VT with AV association. So for that, we need to look at the P waves. Now, lead 2 comes in handy here, though it is also seen in other leads. Let's look at lead 2 in the rhythm strip. You see that there is a small deflection before each QRS complexes. You may be fooled in believing that this is P wave and may look like sinus tachycardia to some, but this is actually a T wave of the preceding QRS complexes, and P waves are actually seen after the QRS. You see that there is a small negative deflection after this QRS, but the next QRS does not show any negative QRS, negative deflection, and the next one again shows a negative deflection. So every alternate QRS is followed by a small narrow inverted deflection in leads 2, 3 and AVF, which are retrograde P waves. So this is ventricular tachycardia, which is conducting in 2 to 1 fashion to the atria. And so this is VT with AV association and retrograde 2 is to 1 conduction. Now remember, the atrial activation is not through the sinus node here. The atrial activation is also being maintained through the ventricular tachycardia focus, which is conducting retrogradely in 2-to-1 fashion. And so the atrial rate is exactly half of the ventricular tachycardia rate. So there is no AV dissociation. And this is an example of a VT which does not have AV dissociation and in fact has 2-to-1 VA association. So a lot of learning and teaching points here. So this is an example of VT with 2-to-1 VA conduction in a patient with old MI and LV dysfunction. Hence, all VTs do not have AV dissociation, or in other words, absence of AV dissociation does not rule out VT. So let me come to the last slide. I'll skip this for the sake of time. So I'll conclude by I not put the concluding slide. So I'll just say that AV dissociation can have multiple causes, and uh, you have to understand that that is not a primary diagnosis. There is always some basic rhythm disorder which is responsible for the AV dissociation, and just saying AV dissociation has no meaning. Second take home point should be that AV dissociation is not synonymous with complete AV block. All patients with complete AV block will have AV dissociation, but it is not necessary that all AV dissociation will have complete AV block. AV dissociation can occur with multiple other mechanisms. One of them is ventricular tachycardia or accelerated idioventricular or idiojunctional rhythm with isorhythmic AV dissociation. So this is a table from my book that I edited, again showing AV dissociation and AV association, and there are examples where the atrial rate is faster than the ventricular rate, same as the ventricular rate, and less than the ventricular rate. So I'll end with that, and I believe that there will definitely be some questions for me to answer. So let's look at the questions.
Yeah, so all of you, if you have any quick questions, we can post it on the chat, but I don't see anything as of now on the chat. Or if somebody wants to open up the line, I can open up the line for a quick discussion or comments.
Also, it's very important to have your feedback so that we can improve in our next subsequent sessions. So please write to us or email us, or even in this chat, you can put your feedback.
If any of you have any particular question, you can unmute yourself. I have enabled unmute. Okay, so I don't think so, sir. We have a question today.
Okay.
The chat and from the line. So I think we can have your concluding remarks before we close the sessions.
So I think I'll thank everybody for joining us, and feel free to ask questions even later in subsequent sessions, or give us the feedback by writing, calling, or writing here in the chat box. Thank you very much for attending.
Thank you, Dr. Karthikeya, for another great curated session away from the conventional AV dissociation first degree, second degree, and bringing the real life examples of the AV dissociation. So thank you very much, all of you, for attending this. The only one request is please give us